Om Amriteshwariya Namaha. Good morning to one and all. Welcoming each and every one of you to this prestigious AMRITA Alumni Meet. As we start off with today's program, I would like to thank our beloved Amma, Sri Mata Amritanandamayi Devi, the epitome of compassion and charity, whose unconditional love and blessings guide each and every one of us. I'm honored to welcome back our esteemed alumnus, Dr.Shrijith Murlidharan.B, from the MBBS batch of 2004 to the AMRITA KOCHI campus. Currently serving as an assistant professor in the Department of Orthopaedics at AIIMS, New Delhi, Dr. Shrijith brings with him a wealth of expertise, having completed his MS, DNB, and fellowship in spine surgery from AIIMS. It is a moment of immense pride to witness one of our own return to share his knowledge and insights on the crucial subject of bone tumors, spine, and limb sarcomas. His academic and professional journey stands as a testament to the spirit of excellence that AMRITA strives to nurture in all its students. We look forward to an enriching and thought-provoking session, and once again, I warmly welcome Dr. Shrijith back to his alma mater. Before moving further, we begin today's session by invoking the blessings of the Almighty by igniting the lamp, a symbol of knowledge, wisdom, and the light that guides us forward in the path of learning and healing. May this light illuminate our minds and inspire us throughout this academic gathering. I request the dignitaries, Dr. P.D. Nair ma'am, Dr. Princey Louis Palati ma'am, Dr. Sita Lakshmi ma'am, Dr. Chandra Babu sir, Dr. Pavitran sir, Dr. Sadesh K. Menon sir, and Dr. Jim Valera sir onto the dais to light up the lamp. Sir, please. I request everyone to rise up. I request the dignitaries to be seated. Thank you all. Please be seated. It is with great honor and privilege that I invite Dr. Prem Nair sir, Group Medical Director and Provost of AMRITA Hospitals, India, to deliver the presidential address. Dr. Prem Nair's exceptional leadership and vision have been instrumental in advancing the quality of healthcare at AMRITA hospitals, making them a beacon of excellence in medical care across India. His commitment to integrating healthcare with education and research has brought tremendous value to this institution, benefiting both patients and the medical community. We are deeply honored to have him with us today, and we look forward to his valuable insights and contributions to the session. Please join me in welcoming Dr. Prem Nair. Over to you, sir.
Om Amriteshwariya Namaha. Distinguished speaker, Dr. Shrijith Murlidharan Nair, MBBS 2004 batch alumnus. I extend a very warm welcome to all of our faculty members, students, staff who are gathered here today. Though we may be physically apart, this online gathering is a testament to the strength of our community, bound together by shared values and a commitment to excellence. An institution's true strength lies not just in its infrastructure or in its academic excellence, but in the legacy carried forward by its alumni. AMRITA Institute of Medical Sciences has nurtured generations of medical professionals who continue to serve in diverse capacities across the world. Yet this journey does not end upon graduation or post-graduation. It is merely the beginning of a lifelong association with the institution. An organized alumni group serves as a bridge between experience and aspiration. It fosters professional connections, research collaborations, and mentorship opportunities, ensuring that our students benefit from the wisdom and expertise of those who have walked the path before them. Such a network is not only a source of guidance, but also a platform for mutual growth where alumni continue to engage, learn, and contribute. Let us commit to creating an engaged and active alumni network that continues to uplift and empower every member of this institution. The connections you build today could shape your career tomorrow. Thank you all very much for this important alumni function. Om Amriteshwari Namaha.
Thank you, sir. Now, it is my honor to invite Dr. Girish Kumar KP, Principal, Amrita School of Medicine, AIIMS Kochi, who's an avid supporter of the Amrita Campus Alumni, to deliver the felicitatory address online. Over to you, sir.
Om Namah Shivaya. Welcome to all the faculty on and off the dais. It gives me immense pleasure to introduce a distinguished alumnus of Amrita School of Medicine, Dr. Shrijith Murlidharan. Dr. Shrijith did his MBBS from our esteemed institution in 2004. His dedication and hard work were evident even during his undergraduate days, laying a strong foundation for his future achievements. Following his MBBS, Dr. Shrijith pursued his MS Orthopaedics from Trivandrum, DNB and Fellowship in Spine Surgery from All India Institute of Medical Sciences, New Delhi. His commitment to excellence led him to his current position as Assistant Professor in the Department of Orthopaedics at the prestigious All India Institute of Medical Sciences, New Delhi. Dr. Shrijith's journey from a bright medical student at Amrita School of Medicine to a faculty member at the leading national institution is a testament to his dedication, intellect, and passion for orthopedics. We at Amrita School of Medicine are incredibly proud of his accomplishments and significant contribution he is making in the field of orthopedic surgery and medical education. We warmly welcome Dr. Shrijith back to his alma mater and look forward to hearing his insights and experiences in the field of orthopedics. Namah Shivaya.
Thank you, sir. A special welcome to Dr. Jayatilak, Professor and HOD of the Department of Orthopaedics. Unfortunately, he couldn't join us due to his busy schedule. Now, inviting the chairpersons of the day. It is with great respect and admiration that I welcome Dr. Chandrababu sir, Emeritus Professor, Department of Orthopaedics, Amrita Institute of Medical Sciences, Kochi, to today's session. Dr. Chandrababu sir is a deeply respected figure in the field of orthopedics whose legacy of clinical excellence, mentorship, and academic leadership spans decades. His contributions to the growth and development of the Department of Orthopaedics at Amrita have laid a strong foundation for the future generation. A true teacher and guide, his presence continued to inspire both faculties and students alike. We are privileged to have him with us today and extend our heartfelt welcome. Sir, please occupy the seat on the dais. Now, it's my honor to welcome Dr. Pavitran K. Sir, Professor and HOD of Oncology, Amrita Institute of Medical Sciences, to today's academic session. Dr. Pavitran Sir is a highly respected figure in the field of oncology, known not only for his vast clinical expertise, but also for his deep commitment to teaching and research. Over the years, he has guided countless students and residents, shaping the future of cancer care with compassion, precision, and academic excellence. His leadership in the Department of Oncology has been instrumental in advancing cancer care at AMRITA. We are privileged to have him with us today, and we look forward to his valuable insights and presence during the session. A heartfelt welcome to you too, sir. Sir, please be on the dais. I'm pleased to welcome Dr. Sajesh K. Menon, sir, clinical professor, head of the department. He'll be joining us very shortly. Now, it's my privilege to welcome Dr. Nair Siddharthan, who will be joining us online. He's a professor and head of the Department of Clinical Hematology and Stem Cell Transplantation at AIIMS, Cochin. Dr. Neeraj is a renowned expert in the field of clinical hematology with special focus on hematological malignancies and bone marrow transplantation. His work has been instrumental in establishing AMRITA as a center of excellence in hematology and stem cell therapy. The strong academic foundation and a compassionate approach to patient care, Dr. Neeraj continues to inspire both students and colleagues alike. His dedication to advancing clinical practice through research and innovation is truly commendable. We are honored to have him with us today, and he'll be joining us online shortly. It is also my privilege to welcome Dr. Jim Valera, consultant in the Department of Orthopaedics, AIIMS, Cochin, to today's session. Dr. Jim Valera is a highly skilled orthopedic consultant with a keen focus on patient care and clinical excellence. His expertise in the field of spine surgery and commitment to providing the highest standard of care have made him a valuable member of the AMRITA family. We are grateful for his contributions to both clinical practice and the academic environment here at AMRITA. It is an honor to have him with us today, and we extend a warm welcome to you, Dr. Jim Valera, sir. Sir, please occupy the seat on the dais. And finally, welcoming the master brain behind this prestigious academic gathering, the chief coordinator for the campus alumnus, Dr. P.G. Nair, ma'am. Emeritus Professor, Department of Pharmacology, and coordinator of the Nodal Office for Statutory Inspections at AMRITA School of Medicine, Cochin. Dr. P.G. Nair, ma'am's vast contributions to the field of pharmacology and a significant role in academic leadership have earned her the respect and admiration of her colleagues and students alike. We are particularly grateful to Dr. P.G. Nair, ma'am, for her invaluable role in organizing this program today, ensuring that it reflects the quality and excellence that AMRITA stands for. It is an honor to have you with us, ma'am, and I extend my heartfelt welcome to you, ma'am.
Namashivaya, I request Dr. Sita Lakshmi Madam to come on the stage as a chairperson, and my special welcome to you, Madam.
Inviting Dr. Sita Lakshmi, ma'am, Professor and HOD of the Department of Pathology. Also welcoming Dr. Ramakrishnan, sir, Professor, Department of Forensic Medicine, and Dr. Divya, Assistant Professor, Department of Geriatrics, Alumni Coordinators, AMRITA School of Medicine, Cochin. And finally, inviting all the people who have joined us both offline and online for this insightful academic session. Once again, I invite Dr.Shrijith Murlidharan.B to share his knowledge and insights on the crucial subject of bone tumors, spine and limb sarcoma, along with their chairpersons, to start off with our session. Over to you, Dr. Shrijith, sir.
So good morning, all. My humble salutations to Amma and pranams to Amma. This is an incredible opportunity which I would like to take, and I thank all my teachers. And I want to start this topic on bone tumors with the permission of the chairpersons. Thank you so much. So I'll be talking on the subject of bone tumors, and in short, I'll give an approach to a limb salvage surgery and approach to the spinal tumors, the current consensus and recommendations. So to put an introduction to the presentation, I will talk about the diagnostic approach, which includes the workup, staging, and biopsy. I'll talk on the brief about the NCCN guidelines to the bone tumors, in particularly the osteosarcoma. Following that, we'll talk in detail about limb salvage surgery with a case example and separation surgery with a case example. We'll conclude with a decision algorithm so that it benefits the general students over there sitting in the audience, and we'll recapitulate the learning objectives at the end. So in the bone tumors, the limb tumors, the commonest presentation is a bony pain, swelling, and pathological fracture. Of the bony pain, it's very typical of a night pain. So whenever a case comes for a bone tumor, it has to be evaluated in a very particular sequence with a history and examination, which is to be followed by X-ray of the local site. For example, if it is a femoral bony lesion, it has to be presented with an X-ray of the local site, AP and lateral. Followed that, we continue with our staging workup, which includes a chest X-ray, MRI contrast, and a PET-CT to assess for any distant metastasis. And then finally, we go for our histopathological diagnosis by doing a biopsy. So this is a symphony of three important sequences which has to be followed like a Beethoven symphony. However, seldom people make mistake in these. For example, in this case, there is a shaft of femur fracture, which on MRI shows a soft tissue component. And you can see the soft tissue component in the thigh compartment. So this patient was being nailed for the shaft of femur, and an entry was also made into the abductors, and a rod was placed into the shaft. This contaminated the entire region, and this case, the sequence of imaging, workup, staging, these all were denied, and straight away a surgical approach was taken up. And this resulted in an external hemipelvectomy in this case. So bone tumors are unforgiving if the sequence of assessing, imaging, and the biopsy is not done and is not taken into an MDT tumor board meeting. Coming to the Enneking staging of classification, grade 1 is considered to be a stage 1. High-grade tumors are considered to be grade 2, and metastatic tumors are considered to be grade 3. So to put in general perspective, all bone tumors are high-grade tumors, especially the malignant ones, the osteosarcoma and AIIMS, which goes into grade 2. And if they have a distant metastasis, it is grade 3. It is a simplified classification, that is the Enneking system of classification. So the aim of the diagnostic workup, which I had shown, is to assess for the staging. And this is concluded by doing a biopsy along with a PET-CT or a CT chest at the minimum to stage the disease, and then only we can formulate a management plan and we can prognosticate the patient in the OPD visits. So NCCN has classically told how the multidisciplinary team works for bone tumors, and it is absolutely imperative that any oncology center should have a team of doctors which includes a medical oncologist, a radiation oncologist, a surgical oncologist, an extremely good pathologist, an interventional radiologist. And this tumor board meeting can conclude for a limb salvage surgery. And it refers to neoadjuvant chemotherapy to start with. Then we go with limb salvage surgery. And following the surgery, we do adjuvant chemotherapy. So it is a joint effort of this entire team, which is termed as a limb salvage surgery, to give an oncological acceptable and functionally good limb to the patient. So for the students over there, this is the mind map for the treatment surgery protocol. That is, you diagnose with a biopsy, you stage the disease, bring the case to the MDT tumor board, and you give neoadjuvant chemotherapy. So during these 3 cycles of initial chemotherapy, you restage the disease and you do a local control by doing a limb salvage surgery. And again, following the surgery, you give the patient 3 cycles of adjuvant chemotherapy. So you can see the surgery is actually sandwiched in between the chemotherapy. And that is why the chemotherapy is most important treatment in the osteosarcoma treatment. So if you ask me the role of neoadjuvant chemotherapy, I think it's the most important role, and the surgeon has equal responsibility to encourage the patient to maintain the compliance to chemotherapy. 2 decades back, the survival rate 5 years of osteosarcoma was 15 to 20%. However, at present, it stays around 65 to 75% in many centers, and that is just because of the advances we have made in chemotherapy. It shrinks the tumor, reduces the tumor edema, makes it more resectable, and it reduces the micrometastasis. So the basic principle about the chemotherapy is cisplatin and doxorubicin are integral components of chemotherapy. It is the confusion in the third agent. Should we add MTX, that is methotrexate, or should we add ifosfamide? So two regimens exist. Of the most common are the MAP regimen, that is the methotrexate based regimen, and the IAP regimen, that is the non-methotrexate based regimen. So in the neoadjuvant cycle, we give 2 to 3 cycles of chemotherapy prior to surgery, and we repeat the MRI and CT chest to reassess the response of chemotherapy. A brief about the two trials, the EUROMOS trial, which was the largest osteosarcoma trial, which tried to assess the response of the MAP, that is the methotrexate regimen. So initial cytoreduction was done because of the chemotherapy. And in the postoperative period, again, the MAP regimen was given. This showed a better response, in fact, a slightly better response than the non-methotrexate regimen. However, it comes with a double-edged sword because methotrexate, when given, need to give leucovorin rescue, aggressive hydration, and there is immense number of toxicity because of methotrexate, leading to higher number of IP admissions. So it substantially increases the cost of treatment. So then came the St. Jude study, which also gave that non-methotrexate containing regimens, that is the IAP regimen, also have similar to good outcomes with 66 to 75% good response in the tumor. So in Indian scenario, where there is a resource limitation, increasing number of IP admission by giving a methotrexate regimen will deplete the resources. That is why in most Indian centers, we use IAP chemotherapy regimen. Same is the case with our institute. We also prefer to give an IAP regimen for most of our cases. So the goal of the limb salvage surgery is a good oncological control. That is the number one. Second is to give a functional limb. And third is to give an early return to mobility. Presently, the only contraindication for a limb salvage surgery is a fungating sarcoma or an unplanned biopsy or surgery, which I showed in the beginning. So now, how much to resect in a limb salvage? This is a very important concept, and the concept was given by the Kawaguchi. So it's called the Kawaguchi's concept. So the image on the left you see, the blue is the tumor. So when you see this tumor and you resect the tumor with a normal cuff of tissue of all around 360 degree with a 3 centimeter margin of normal muscle, it's called as the wide excision. So that is what we attempt in limb tumors. Whereas in a spinal tumor, you can't resect out the normal tissues all around the spinal because there are important vital structures like spinal cord and aorta. So you do an intralesional excision. You remove the tumor and you debulk it and you do a decompression of the thecal sac. So in the spinal cases, we do intralesional excision, whereas in a limb tumors, we do a wide excision. So how much to resect is based on the concept of barrier. So barriers are anatomical structures which offer resistance to tumor invasion. That includes fascia joint capsule. For all practical purposes, white glistening structures like physis, like thick fascia, like ITB bands, they're considered to be thick barriers, whereas thin barriers are adventitious of neurovascular bundle. So whenever you have a thick barrier, you can minimize the amount of soft tissue which has to be removed along with the tumor. So you can potentially avoid a disfiguring surgical resection. So that is the importance of barriers given by the Kawaguchi concept. So the rules of the resection is, at the end of the procedure, major neurovascular bundle should be free of tumor. You should do a wide margin resection with a normal 3 centimeter normal cuff of muscle tissue all around the tumor. All previous biopsy sites should be removed and blocked with the tumor. And to avoid intraosseous tumor extension, the bone should be resected 3 centimeter more than the bone tumor lesion. So if it is a 10 centimeter tumor in the bone, the resection has to be 10 plus 3, that is 13 centimeter. And you should have an adequate soft tissue coverage to decrease the risk of skin flap. So these are the 5 rules which have to be followed for the limb salvage surgery. Coming to a case example, you can see this is a 17-year-old male patient with proximal femur aggressive lesion. You can see a wide zone of transition, periosteal reaction. So this was the chemo, pre-chemo. And if you look at the post-chemo image, it is presently the tumor has shrunk. You can see the periphery borders of the tumor, which now has calcified. So it becomes easy to resect. And these are the MRI pictures. You can see the marrow tumor into the shaft, proximal femur. And the length of the tumor is almost around 11 centimeter. In the axial image, you can see the femoral vessels are free of tumor. So this patient was being taken for a limb salvage after doing a biopsy. And biopsy was done outside and he was referred to our center. So this was the biopsy scar. This is the biopsy track. This is the ASIS and this is the greater trochanter. So we had done a posterolateral approach and we had tried to incorporate the biopsy scar also along with the incision. So in this next slide, if you focus on to the numbers, it will become easy for you. So in the slide 1, if you see, we've done a posterolateral approach and we had dissected out the gluteus maximus and facial lata is also opened. Following that, we had continued into the posterior dissection, tried to preserve the sciatic nerve by identifying the Gmax tendon, which was cut open so that the posterior approach can be done. Following this, the vastus lateralis was mobilized and short external rotators, that is the cortatus femoris, was dissected and cut. Following this, proximally, we have released the abductors with a normal cuff of tissue around the GT. And following this, onto the medial side, we have tied the profunda branch. This is the capsule of the femoral head. This is the GT, and this is the vastus lateralis, which we have released out. Following this, a T-shaped capsulotomy was being done, and the femoral head was delivered out. So once we deliver out the femoral head, you can see the tumor with a normal cuff of tissue all around. And if you can see, we are giving a margin of normal cuff tissue also. So in the pre-op, it was 11 centimeter of bone tumor. So 11 plus 3, we have resected 14 centimeter of the proximal femur. Following this osteotomy, there is the marrow which we send to frozen. And once the frozen comes as negative, that is when we start our reconstruction and we put a proximal femur trial implant and we check for the stability and antiversion. Following successful trial, we do endoprosthesis reimplantation with cement into the femoral shaft and reduction is done. Following this reduction, the most important is a soft tissue reconstruction where we reconstruct the Gmax, vastus lateralis, and the abductors are tied to the implant. And then we repair the TFL, that is a tensor fasciae lata, and the gluteus repair is being done. So following this, the most important thing is to send the specimen for histopathological examination In this, we have sent for the histopathological examination, where the pathologist cuts open the specimen and they make grids all around the tumor and they assess each grid for tumor necrosis because of the pre-op chemotherapy, which I have mentioned. So when they assess the necrosis factor, if more than 90% of necrosis is seen in the histopathological sample, we continue with the same regimen, which was followed up in the pre-op. And if there is less than 60% necrosis, that is poor response, we have to bring the case back to the MDT to assess for any change of chemotherapy regimen. So this is how a general workup and the treatment follows for an osteosarcoma. Once we do the surgery, we send for them for rehabilitation and they complete the adjuvant chemotherapy. And follow that, we follow up them in every OPD visit. So our schedule for OPD visit is 6 monthly for the first 3 years. And we follow up with simple chest X-ray and a local site AP and lateral. And then once per year, we evaluate them in our OPD clinic if they are free of tumor after 3 years. This is something we have followed up from the TOS clinical trial, which was done by the TMH group. So this is in short about the treatment and the follow-up aspect of the bone tumors in the limb. So I go to the second part of the lecture, that is the spinal metastasis. What are the approaches and the current recommendations for spinal metastasis? I start with 2 case examples, and then we'll go into the recent advances which have happened in spinal metastasis and how important it is to assess the spinal tumors through a clinical algorithm will be explained in this lecture. So this is the case example 1. That is, there is a CA breast survivor. She has been surviving post-chemotherapy and surgery for 3 years and presently has developed a paraparesis with L1 and L3 spine lesion with a mechanical pain. She has come to us with bilateral lower limb power 1/5. This is the imaging of this patient. And these are the treatment options, which includes steroids, radiation, surgery, en bloc plus radiation. So these are the platter of treatment options. And at the end of this lecture, we'll get to know what is the best optimal treatment for this patient. This is again a case 2 example, CA rectum early stage on remission, now presenting with a L5 vertebra lesion and presented with acute onset paraparesis and bladder deficit. So these are the 2 case examples which I would like to discuss at the end of the lecture. So coming to the lecture itself, what is the need for studying metastatic diseases of the spine? So skeletal system is the 3rd most common site of metastasis. And this number is going to increase in the coming decades because of the advances we have made in chemotherapy and radiation oncology. More patients are surviving. And that is why we get more number of spinal metastases in the coming future. Spine is the most common site with 70% of all malignancy presenting with metastatic spine disease and 15 to 30% presence with symptomatic mechanical pain or neurological deficit. So that is the reason why we need to study about metastatic diseases. Coming to a brief evolution of the treatment. So before 2000, whenever we had done a systematic review of all the cases prior to 2000, we have seen when the radiotherapy alone is being given, there is only 44% of improvement in the patient, which is sustained for 6 months. So worldwide treatment of choice was radiation alone. And if you look at the past surgeries before 2000, the only surgery that can be offered by a surgeon was to do a laminectomy. So laminectomy is posterior removal of the lamina, whereas most of the metastatic tumors are into the vertebral body. So the compression still remains over there. So there was again a dismal response to the treatment, and undergoing all the morbidity, the response was only 44%. So till early 2000, there was no clinical standard operating protocol for treating these diseases, and they were subjected to radiation only. but clinical outcomes were not encouraging as mechanical stability was always ignored. So this is the bedrock paper which has come up in metastatic diseases of the spine. This was a randomized trial which was published in Lancet. In this, the Roy Patchell et al., they did a prospective randomized trial for all the solid tumor metastatic diseases, and they found that whenever there is a high-grade spinal cord compression with myelopathy, they assess the response of surgery with radiation versus radiation alone. And they found whenever the radiation was being offered and whenever a surgery was being offered with subsequent radiation, there was overall increased amount of ambulation, the bowel bladder deficit improved, and the requirement of narcotics for pain relief also reduced. So there was a strong recommendation for high spinal cord compression to be treated with surgical decompression and stabilization to be followed by RT. Looking at the parallel world of radiation oncology, there were subsequent advances being made post-2000. For example, if you see the conventional RT, whenever radiation is given to the vertebra, there is a lot of radiation scatter. So whenever we give a radiation to the vertebral body, the radiation was also affecting the visceral organs in and around the vertebral body. For example, into the GI, along the heart, and onto the vessels, and to the renal tissue. So the conventional RT, the surrounding tissue was also undergoing severe complications, whereas the new child in the block, that is the SBRT or the SRS, which was developed in 2000 post, whenever the SBRT is being given, it's a pinpoint focal high dose radiation which is being given. And if you can see that there is less amount of radiation scatter into the surrounding tissue. So more pinpoint focal cytoablative doses can be given by SRS or the SBRT radiation. So this was something which was very, very important, which had come in the new decade. And this was the study which was being done at the MSKC Cancer Center in New York. They assessed the response rate to both conventional and the SRS or SBRT radiation. What they found was conventional RT always had the restriction of tissue histology. There was radiosensitive tumors and radio-resistant. So radio-resistant tumors, the local control by a conventional RT was only 30% in 2 years follow-up. Whereas the new child in the block, that SRS, irrespective of the tumor histology, all tumors were radiosensitive because we are giving cytoablative doses, but with pinpoint accuracy. So 2-year local control response was almost 98%. However, there was a caveat to this SRS. That is, in cases when you have high-grade spinal cord compression, like in this case, you cannot give cytoablative doses to tissues in and around the spinal cord because it will ablate the tumor tissue as well as the spinal cord also. So that is why there was high incidence of local failure whenever there was a high-grade spinal cord compression, like in this case. And if you see onto the right side, there is a chart of organ at risk. So the OR toxicity doses, if you see, the spinal cord is something which is very sensitive to doses of 14 Gray also, which can lead to myelitis. So in high spinal cord compression, if we give SBRT also alone, there is a chance that the spinal cord can get myelitis, and the response will be very less. You can see when the radiation is being given, it affects the spinal cord also. So caveat 2 was high local recurrence was seen in high-grade spinal cord compression. So what is low-grade and what is high-grade spinal cord compression? And the response to this answer is the Bilski grading system, what we follow in our institute also. So in this, if you see, the red is the vertebral tumor, which is into the vertebral body. So grade 1, the thecal sac is only abutted. however, the cord is not compressed. So all cases where the cord is not compressed, they are classified as low grade or the grade 1 Bilski score. Whereas in cases when the vertebral tumor comes into the canal and compresses the spinal cord, that is grade 2 and grade 3, these are the cases we cannot give straight away SBRT, as it can also affect the spinal cord. So in grade 2 and grade 3, we need to do a surgical intervention by doing a laminectomy, bilateral pedicles to be removed, so that the cord has a breathing space, and you do a 360-degree cord decompression to provide a radiation corridor so that the radiation can ablate the tumors into the vertebral body without affecting the spinal cord. I'll come to this once again. So that is how the concept of separation surgery which came, and it is nothing but a 360-degree decompression of the spinal cord. You do a mechanical stabilization of the spine. Following that, you do a laminectomy, you do bilateral pedicles removed, and you free the nerve tissue. So you can see the nerve is decompressed and posteriorly and laterally. And followed that, you use a Woodson Penfield and you break the PLL so that anteriorly also the decompression part is done. So to assess whether the 360-degree decompression is done, we routinely do a intraoperative ultrasound of the spinal cord to assess the 360-degree anterior decompression also, so that the tumor all around the spinal cord is decompressed. So this is the concept of separation surgery, that is 360-degree decompression of the spinal cord. So this became the game changer, and the hybrid surgery concept was introduced, which includes the separation surgery in stage 1, followed by stage 2 of SRS. So you can see the case which we had discussed previously. So in this case, a separation surgery was done. We had decompressed the spinal cord all around 360-degree, and we had given a radiation corridor so that radiation can be safely given. So this is the concept of stage 1 separation surgery to be followed by SBRT or SRS. So when to stabilize a spine, that is being guided by the SIMS criteria. This is a 6-component criteria, which includes the location of the tumor, the pain factor, bone lesion, alignment, body collapse of the vertebra, and posterolateral involvement. Following that, we do a scoring system. So potentially all scores which accumulate more than 7, they are potentially unstable and have mechanical pain, which need to be treated with either one of these: vertebroplasty, percutaneous pedicle screw, or an open surgery. So combining together, the MSKC came up with the framework, which is called as NORMS framework, to treat the spinal metastatic tumors, which all over the world is followed in the cases of spinal metastasis, where N stands for the neurology, O stands for the oncological outcome, M stands for the mechanical pain, and S stands for the visceral systemic metastasis. So this is a busy slide, but the crux of the matter is, whenever you have a mechanically unstable spine, through a SIN scoring system, you stabilize it. Whereas in cases you have high-grade spinal cord compression, that is Bilski grade 2 and grade 3, you do a separation surgery in stage 1, followed up with an SBRT. So this is the crux of this chart. So to make it very easy, do we have an algorithm for this problem? So every patient is unique, and we have an algorithm which we follow. That is, we bring all our patients to an MDT and we assess the medical condition, performance status, and we assess and deliberate on the question, will he tolerate the surgery? So any patient who has a quality life more than 3 months need to be given an aggressive approach. That is what we follow. Second critical question is, what is the clinical presentation. And as discussed previously, we classify the neurological compromise on the base of grade Bilski score. The Bilski score, if it is 2 and 3, we go for a separation surgery approach. We assess the spinal instability based on the SINS score, and we assess on the PET if there are any visceral metastases. So visceral metastasis is one of the contraindications for doing a surgical approach that has to be noted up. And critical 3 issue is we deliberate among our team and assess, can a feasible surgery be planned? So these surgeries are palliative and consent must be taken for the palliative surgery. We do a marginal resection or a debulking of the tumor with decompression of the spinal cord all around and give stabilization to the spine. For early, durable, functional benefit, we give a stabilization of the spine if the SIN score is more than 7. So coming together to the question we have started in the beginning, this is the L1 lesion, which is compressing onto the spinal cord. And there is also an L3 lesion, but it is not compressing onto the cord. So assuming that the patient is fit, we assess what is the neurological status. So it is 1/5. So there is neurology is involved and it is evident on MRI also. So this is a Bilski grade 3 lesion and the SIN score is 10. So it is potentially unstable. So with the norms framework, it comes as hybrid procedure that we first do a separation surgery followed up with the radiation. And separation surgery, as I told, it's circumferential decompression. So in this case, we have opened up from D11 to L4 and screw instrumentation was done at D11, D12, L2, L3 and L4. In this case, we have done a posterior laminectomy, followed that the tumor and the bilateral pedicles were also removed. So we have done a posterior laminectomy and bilateral pedicles. So we have decompressed the cord and followed that you can see we're trying to break the PLL. Following this, a 360-degree decompression is being done. And to confirm the 360-degree decompression, we do an intraop ultrasound and follow that with a vessel loop. This loop is a 4 mm loop, which is passed all around the spinal cord so that the anterior decompression is confirmed. And this is the post-op X-ray, where this was the tumor site, the L1, which can be given radiation now safely, as we had created a radiation corridor and we had decompressed the spinal cord. Coming to the case example 2, this was a quadri-poinar syndrome with an L5 spinal tumor, which is compressing the thecal sac. Again, you can see in these axial images, there is complete thecal sac compression. So again, assuming the patient is fit, the Bilski grade 3 neurology is involved and SIN score is 10. So potentially unstable. And with the norms framework, we again do a separation surgery in first stage, followed by an SBRT. So in this case, this is the cranial end, this is the caudal end. L5 is where the tumor was. This was L4, where we have instrumented with a screw, S1 and S2. And this is the tumor site, which we see. And you can see there is posteriorly, there is a lot of tumor tissue along. This was decompressed, and this is what we could achieve. A thecal sac decompression was being done. We have removed the bilateral pedicles, and a radiation corridor could be achieved. And the nerve root L5 and S1 were decompressed throughout. Since it was an L5 lesion, a junctional lesion, we have to put cemented screws because of osteoporosis, and we had to go into the pelvis because of the junctional area. So spinopelvic fixation was being done. You can see this was the L5 tumor, which now can be safely given radiation. And we have put the transverse connectors above L5 so that less amount of radiation scatter happens in this case. So this is how we follow a protocol-based approach in cases of spinal tumors. So the take-home message of this presentation is, whenever case comes of a limb sarcoma, osteosarcoma, most common is the osteosarcoma, we need to assess the patient, stage the disease, do a biopsy, confirm the diagnosis, bring it to the MDT, and start on chemotherapy, 3 cycles, which need to be followed by surgery, and again, post-operatively, 3 cycles of adjuvant chemotherapy should be given. So this is how the protocol is, and surgery is always sandwiched in between the cycles of chemotherapy. The most important treatment aspect is neoadjuvant chemotherapy in cases of limb osteosarcoma. In cases of spinal metastasis, we need to assess which case need to be operated based on to the neurological deficit. It is only in grade 2 and grade 3 Bilski score we intervene surgically. And if the SIN score is potentially unstable, we need to do a spinal stabilization, and we follow the norms framework. So it is a practice of doing a surgical decompression, and these cases have to be referred back to the radiation oncology for adjuvant RT in cases like these. So this is the take-home message. And with this, I want to conclude the presentation. At the same time, I'll be very happy to take some questions and constructive criticism. Thank you so much for a patient hearing.
Thank you, sir. Thank you for that academically enriching talk. So now the floor is open for discussion, and I request the chairpersons to occupy their seats on the dais. Dr. Chandra. So I request Dr. Chandrababu, sir, to start off with the discussion.
Dr. Shrijith, there is a very good presentation, not very good, excellent presentation.
Thank you, sir.
Because it is a very tough topic for all of us. And from orthopedics, very few people opt for this specialty because of multiple reasons. But I remember Paudran sir asking me to send somebody for this. And I tried, but many people are not very happy with it. There are 2 reasons basically. One is, the number of cases, when you compare with all other specialties, this is not that much. So in Kerala, as it is, there are only one person who is doing orthopedic oncology only, and he is running all around. So you can understand the reason why it is happening. Well, anyway, and the second problem is there are so many uncertainties with this. Having said all those things, I'm making comments only. I'm not going to ask you a question, Shrijith.
Sure, sir.
Because I think that is more important. The key factor in the management of these sarcomas is the clinical diagnosis. We all now are going into a stage of investigative diagnosis. You send the patient for MRI, you have no diagnosis, and MRI people will give you a diagnosis, you treat MRI. This is what is happening. This is the tragedy in orthopedics. Paudran sir knows many cases like this. We have discussed a number of cases which is happening. Sir, I remember many situations which happen like the reason is, there is a lot of, if you look at the images, osteomyelitis mimics Ewing sarcoma. Not only clinically, radiologically, everywhere. So there are certain key factors, your skill to make the diagnosis between a sarcoma and infection. Well, we are going to conduct this course, 2-day course. You are aware, sir. Your people are also coming. Pathology people are also coming. So we'll have a multiple department discussion here for 2 days, this Saturday and Sunday. All of you are welcome for that. Okay, 20 cases we are discussing like this. Each case from the starting point. Starting point where the patient came, then what next, and 10 years it goes, or even more than it goes. So you will understand what happens to these patients as time goes on. Okay, so Shrijith, once again, congratulations. It was an excellent presentation, and we are very proud of you. Have done it so well. Thank you very much.
Thank you, sir.
Shrijith, it was an excellent presentation. I have 2 questions. One is, are you using limb perfusion chemotherapy?
So for soft tissue sarcomas, we are using yes. For bone tumors, we are not using isolated limb perfusion, sir. The response rate is very less, and it is coming up with a lot of toxicity. So we're not using isolated limb perfusion in bone tumors, sir.
And extracorporeal radiation reconstruction?
Absolutely. I think that is something we do very often. And to be precise, this was out of the scope of the presentation. So that is why I have not included that biological part. But whenever possible, we give biological reconstruction because that is the best surgical option that we can give to our patients. Because once it heals, the bone unites, it unites for permanency. Whereas in cases when you put implants, they all fail after 5 to 10 years because of the polywear. So the patients have to undergo multiple surgeries. So absolutely, we always follow, whenever possible, a biological reconstruction, which is an ECRT technique.
And how often you use molecular diagnostics?
So we, in the recent times, we have started using molecular diagnosis, and it is imperative. And we also use NGS, next generation sequencing for our patients, which have started in the recent times. And we shortly will have a good database on these cases.
Thank you.
Thank you, sir.
Excellent talk, Shrijith. Jim here.
Sure.
I wanted to know your take on cement augmentation in those secondaries.
Yes, sir. So, secondary cases, whenever they present in the cases, they are elderly gentlemen. So they have osteoporosis. Second, they are already weak because of the cancer cachexia. And third, because of the tumor per se. Because of these three reasons, the bone quality is not as good as the normal people. So in these cases, what we do is we use bone cement augmentation. But in these cases, we are very careful in the intraoperative period. We inform our anesthetist so that they can go for if there is any cardiac issue or there is an embolism, they can go for resuscitation. But we generally use cement augmented screws in metastatic cases also.
Thank you.
Thank you, sir.
Shrijith, Dr. Lakshmi here.
Hello, ma'am.
Hi. Whenever from the pathology side, when the biopsy comes and when it is a small biopsy before the surgery, if it is a classical case, it is easy. So we always discuss all the cases with the clinicians, then compare with they'll give a detailed description of the case with the radiology and then pathology. So when a small biopsy comes, actually the clinical examination and the radiology evaluation becomes the gross finding for us because we are getting a very small tissue. So if it's a classical case, like in osteosarcoma, I'm talking only about osteosarcoma. So if it is a classical case, it's very easy to diagnose because you will see pleomorphic spindle cells with all this thing with the osteoid background and all. But it is not so in many of the cases. So the classical appearance, if it is there, it's very easy on a small biopsy with the typical radiology and clinical presentation. But once when the chondroid tissue predominates, sometimes fibroblastic tissue predominates sometimes, and sometimes vessel predominates like in the telangiectatic variant. And sometimes what happens, it will just look like small blue round cells. So then when the differential is so vast, starting from the lymphoma to the polydifferentiated carcinoma. So that is when a small biopsy comes, actually it's a challenge to pathologists. So in a classical case, it is easy, but we may have to resort to immunohistochemistry and other ancillary techniques for the diagnosis. And we always discuss it out in a clinical radiology pathological meeting to have a final opinion on that. And about the surgery after the chemo also, that's also a challenging part because we have to assess the percentage of necrosis in that. So whatever you have described as it, like it is we take a serial with a grid pattern to take the samples. and assess the cellularity and the necrosis part and the tumor part. So we have to tell like whether it is all tumor is gone or it is less than 10%, only necrosis is there, like that. So depending on that, your management later changes also. It was a nice, excellent presentation, Shrijith, and congrats with the updates. Thank you.
Thank you, ma'am. I truly appreciate your comments, ma'am. That is why MDT is of the most important, and pathologist is a very, very important member because that makes the diagnosis. Exceptional cases, we burn our heads in cases of ABC, GCT, and it gets confused. And at the end of the day, we can have surprises like a telangiectatic osteosarcoma. These has happened, and when they happen, they are disasters. So all cases have to be taken through the MDT. That is what we follow. Thank you so much, ma'am, for your comments.
Thank you. Thank you, sir. Are there any queries from the audience? Any questions?
Wonderful presentation that was very lucid and clear for even a pharmacologist like me. Okay, and I just need to know the two types of therapies, that is MTX based and IAP based. What is the safety profile and efficacy in either of this? Is it the same or is there a difference?
That's a very, very important question what madam has asked. So regarding the safety protocol, ma'am, to be on perspective, a methotrexate-based regimen, that is a MAP regimen, is slightly better efficacious than the IAP regimen. But that percentage is only around 3 to 5%, or it can extend to 10%. But for that matter of the fact, the patient needs to be managed of toxicity because we have to load almost 12 gram per meter square of methotrexate. And this requires a lot of aggressive hydration and recovery and rescue. And you have to monitor the level of methotrexate. So frequent IP admissions have to be done for these cases. And this increases the cost of the preoperative chemotherapy, which can go into lakhs, maybe around 10 lakhs, if I am not wrong, in multiple centers in private institutions. So the overall cost gets add on for a benefit of 5 to 10%. And IAP studies, you can see the response rate is as good as a non-methotrexate regimen. So to take into perspective, MAP versus IAP, IAP is a better regimen in a resource-limited setting like ours, developing countries. And this has been proved up in many centers in all across India that IAP chemotherapy is a viable and a cost-effective option. So efficacious wise, MAP is better, but in an Indian setting, we need to assess and balance our resources also. So IAP is what we follow, and it is as good as MAP regimen, which is being followed mostly in the Western countries.
We here mostly follow MAP, and because we have monitoring facility and toxicities are manageable,
Yes.
and no mortality so far.
So that's excellent because AMRITA is a setup where all facilities are there. And in our place, we have limitations. So that is why not many cases we follow MAP regimen. But yes, MAP is a much better. And in specialized centers, only it can be managed like on AMRITA and TMH. In some cases in TMH, they are also given.
May I add one more question? What is the rate or frequency of secondary resistance to osteogenic sarcoma, to the drugs?
To the drugs?
Yeah. Do you get cases
Yes,
of?
yeah, absolutely, ma'am. So that is where this slide comes into perspective because we are not knowing what is the response to these chemotherapies. That is why we try to assess after the chemotherapy, preoperative chemotherapy, the surgery is being done, and we assess who has this resistance and who are the responders. So we need to find the R, the responders or the resistance. So for that, we send the specimen to the pathologist and it is the pathologist who tells us what is the tumor necrosis factor. So if it is less than 60%, we know that they are not responders and they are resistant to the pre-op chemotherapy regimen. So we bring the case again back to the MDT and assess for any change of the response to the chemotherapy by adding newer chemotherapy agent or by changing the regimen totally.
So, if there are no further questions, we'll move on to the handing over the mementos to our chairpersons. First, I request Dr. P.G. Nair ma'am, by Dr. Princey ma'am, to hand over the memento to Pavitran sir. Ma'am, sir. Thank you, sir. Thank you, ma'am. Okay, I request Dr. P.G. Nair ma'am to hand over the memento to Dr. Chandrababu sir. So please. Thank you, sir. Thank you, ma'am. I request Dr. Mahesh Kumar sir, Professor, Department of Pharmacology, to hand over the memento to Dr. Jim Valera sir. Thank you, sir. Now I request Dr. Tanya Mary Thomas, Additional Professor, Department of Pharmacology, to hand over the memento to Dr. Sita Lakshmi ma'am. Ma'am, please. Thank you, ma'am. Now I invite Dr. Shalini Thomas, MD Resident, Department of Pharmacology, to deliver the vote of thanks.
Om Amriteshwaraya Namaha. Good morning, everyone. On behalf of the organizing team, it is my privilege to deliver vote of thanks for today's insightful orthopedic session. First of all, let me thank Amma for providing us the state-of-art facilities for learning. Next, I express my sincere gratitude to our Medical Director, Dr. Prem Nair sir, and Principal of AMRITA Institute of Medical Science, Dr. Girish sir, for their unwavering support and encouragement in making the session possible. Next, I extend my gratitude to our distinguished speaker, Dr. Shrijith Murlidharan sir, for joining us online and sharing his expertise with such clarity and depth. Your talk was truly enlightening and has made immense value to our understanding of this complex subject. It is my obligation to express my heartfelt indebtedness to Dr. Jaitilak sir, Head of Orthopaedics Department, in his absence. We are grateful to our esteemed chairpersons, Dr. Chandrababu sir, Dr. Pavitran sir, and Dr. Sajish Kemer sir, for enriching the discussions. Special thanks to our esteemed chairpersons, Dr. Jim sir, Neeraj sir, and Sita Lakshmi ma'am for their presence. And I extend my gratitude to Dr. P.G. Nair ma'am, Emeritus Professor, Coordinator of Nodal Office of Statutory Inspection and Chief Coordinator for Campus Alumni, whose efforts in organizing and coordinating the program have been instrumental in making today's sessions a success. Also, alumni coordinators of AMRITA School of Medicine, Dr. Ramakrishnan sir from Forensic Department and Dr. Divya ma'am from Geriatrics Department. I thank the audio video team and AOC team for providing all facilities, and thank Brahmacharini Karnaji for her catering services. Last but certainly not least, we thank all the delegates who joined us both online and offline for being a part of this academic gathering. Your active participation is what makes this session like this truly meaningful. Thank you all. Please rise for National Anthem, which will be played on violin by Dr. Siddharth Vishwanath, our alumni from 2002 MBBS batch, who is currently working in CVTS department here.
So it is important for you elsewhere, whenever you go, abroad especially. So please register, give your names and go. Just sign. There is a paper there and the registration counter. Madam.
Madam, I want to take 2 minutes.
Yes, sir. Yes, sir.
Ma'am, I want to take 2 minutes and I want to express my thanks. First of all, Om Amriteshwari Nama. I want to thank Amma first for giving me the opportunity to do an undergraduate course at AMRITA Institute, which is one of the leading institutes in this country. And I'm very proud to be inherent of that culture. Secondly, I want to thank Professor Prem Nair sir, Professor Chandrababu sir, Professor Jim Vellera sir, Professor Pavitran sir, Professor P.G. Nair ma'am, Professor Sita Lakshmi ma'am, and all the faculty members who have taken time to listen to this talk. This has been an incredible opportunity, and I want to thank each one of you. I have been associated somehow with the medical oncology team in the beginning of my career when I was doing my house residency. And I just have a couple of images, so which I would like to share with each and every one of you. So this was, I had worked for almost 5 months in the department in post my house residency. And this is one of my dearest team, which have shaped my interest into oncology. Dr. Wesley, Dr. Asmita ma'am, I'm sure she is working there in AMRITA. So this was my early days. This is my early days with my one of my favorite professors, Professor Ganapati Rao sir. We had gone for a marriage ceremony of our batchmate. So this is one of the pictures during that function. So this again, our beloved, very beloved principal. He's always there for us, and MGK sir and all favorite Sudhindra sir. They all had come for our graduation party, and we really had a great time. So this was our graduation ceremony party. This is our boys gang, all boys gang trip, and you can see the youngest member there in our team, the Pratama sir. He always used to accompany for all our group meetings, and we really enjoyed his company. This is my family. This is my wife Harita and my son Harshit. My wife is an intensivist, and she is working as a lead consultant at Apollo, Delhi. So this is my family, and this is my batchmates. So this is one of the dearest pictures which I have. That is we all along with Amma, and this is something very incredible. So these two pictures, if you see 1 and 2, this makes my 2 decades which I have lived through. So these are very dearest things which have happened to me, and I have only one word to say to you all, that is gratitude. Gratitude to Amma, gratitude to the Institute. Thank you so much.
Thank you, sir. Thank you, sir, for sharing all those heartfelt memories with us. Thank you, sir. Thank you so much.
Thank you.
So with this, we have come to the end of the session. Thank you all for joining us. Thank you so much. And thank you, Shrijith, sir. Thank you.
Thank you.